And as Marcus said before, we also, and you have seen the picture, we also transfer the hinge axis onto the patient's skin, and then we are putting a little metal piece onto the skin, and with these metal pieces, 1, 2, 3, we send the patient to the cephalometric machine, so that we in the Ceph analysis also can see the same plane, so that our analysis from the Ceph skeletal analysis also relates to all our coordinate system findings in the articulator. So this is very important. So you can see here. It's nearly so fast as me. Question. Question? Yes.
보통 저희들이 페이스북 이제 트랜스퍼 한다고 하면 결국은 상악이나 크레니오
Now we can mount.
관계를
Okay.
이렇게 옮기는 과정인데 이제 결국 추후 힌지 엑시스를 가지고 이제 옮기는 거잖아요. 그러면 이제 하악의 무브먼트나 하악의 이제 엑시스를 가지고 옮기는 건데 그러면 그 두개골과의 관계, 두개골의 어떤 그런 거에 관계는
wir marken this position with scar und position für die Oberkiefer mit scar. Jetzt ist mit hinge axis orbital.
Ja.
Ist das ein bisschen unterschiedlich? Wie kann man das?
Zum konventionellen Gesichtsbogen, ja.
Ist das Unterschied?
Sehr großer Unterschied. Wenn er einen Ohroliven-Gesichtsbogen, einen konventionellen Gesichtsbogen, im Durchschnitt, dieser hier, ja, er meint diesen hier, ja?
일반적으로 사용하는 것이죠.
Dieser Gesichtsbogen arbeitet mit einem Mittelwert. Das ist im Ohr und der Mittelwert, das hier soll Hinge Axis Point sein, 1 Zentimeter weiter anterior. Wenn wir uns vor Augen führen, 0,75 Millimeter im Gelenk spielen eine Rolle.
여기서 말하는 거지 0.75mm를 갖고 따지는 거기 때문에 지금 이런 평균치값하고는 차이가 많죠.
Mit diesem Bogen fangen wir bei einem Fehler von 10 Millimetern an.
벌써 이거를 시작하는 순간 10mm만큼의 차이가 잘못돼서 시작을 하는 거기 때문에 정확도가 훨씬 떨어진다.
Okay. Maybe you can look to these pictures.
Yeah.
Okay. This is from the year 1974. It was a master's thesis by a Dutch doctor, Boersma, and when you see, he compared the true hinge axis to the different methods, okay? And he found out that a simple palpation method was more or less this field of exactness, okay?
방법에 따라서 저만큼의 오차들이 많이 생긴다는 거죠.
Yeah. Using the anatomic arbitrary phase bow, he will be in this range, okay, to the true hinge axis. When he goes to a kinematic method, like we use here, you can see that we are very, very fine. Okay, and this is just on laboratory. Okay, this is of no interest. But we're working here, and maybe, yeah, you also can look to this picture here. Okay, this is not. This is not so interesting for TMD. This is interesting for prosthetic dentistry. Okay?
저쪽에서는 저런데
그러면 추루 힌지 엑시스라고 하는데 상황에 따라서 추루 힌지 엑시스가 변할 수도 있는 거 아닌가? 그러니까 하악이 변하면 이제 이게 어느 정도 기준점이 변하는 거니까 신뢰도가 그러니까 이제 그 데이터의 차이가 있지 않을까? 추루 힌지 엑시스가 변할 수 있는지 없는지
이제 True Hinge Position kann das verändern? Von einem Patienten und das Hinge Axis verändert das manchmal, wenn jedes Mal messen, dann ist es die True Hinge Position.
Ja, räumlich kann sich das verändern. Ja. Das kann sich verändern. Biologie. This is biology. Of course there is maybe some changes. Of course, there's some changes, but not very much. Most important, geh nochmal einen Slide zurück, bitte. Important thing. This value, 1.7 millimeters, exactness, is acceptable. There is other research says that about 3 millimeter away makes occlusion error, like in the next picture, of 0.1 millimeter. 0.1 millimeter in crown is too much. We have to grind. So if you want precise occlusal surface from the lab, you need to have true hinge axis below around 1.7 times 1.7. You can only get with this mechanical method. Otherwise, impossible.
Well, just think on one simple thing. You are mounting your lower model with a centric plate, right? This is true. So this means you have, when you mount to the articulator, the lower to the upper, you have a plate this thickness. Okay? So now, depending on your displacement of the mounting to the true hinge axis, you may be lucky. Okay? So it would be 1, 3, or 5 position here where you don't have an error. But you can be very unlucky, which means position 2 or 4, where you have a big error in occlusion. This means in terms from when you think quality, reproducibility, things like this, the true hinge axis is the only way you can really go with that. Okay? Whenever you have rotation, and watch the next picture, which is an extreme example. Okay? This is the same casts here and here, the same casts.
And
It's the same centric plate, but it's on a different position in the articulator. And now, watch, now we take out the centric plate and look to the result, to the different positions. Is it the same patient? Can you see here and compare to here? You see the difference? So it's a total different contact situation. Can you see this? It's the same patient, it's the same cast. It's just a different position, and this is the rotation. Okay? And therefore you should consider this picture, and you should consider this.
very easy. Everybody knows this example. You're doing crowns, tooth number 7, upper jaw. How many times you have to grind? Every time.
Every time.
Not every time.
Never.
Often?
Almost always.
Almost always. And this is exactly this. It's not dental technician fault. It's our fault. Because we're not using this. Mounting is incorrect. This is why. Because closing movement simulated in articulator must be correct. If you use this face bow, you have 65% chance of being here. 65% chance with this one. 100% with this one. What do you want?
저렇게 힌지에서 저렇게 잡아놓으면 이 버티컬로는 이게 인간의 중심하고 또 맞다고 볼 수 있습니까?
뜻이죠?
힌지 엑스를 잡아서 마우팅했잖아요. 네. 모형이 수직된 포인트가 인간의 중심 전환과 맞다고 볼 수 있는 거죠.
Please translate.
만약 안 맞으면 저거를 전치고 고철이 틸팅된 건 어떻게 맞죠?
the hinge axis is so horizontal, but the Körper midline ist das richtig Position, also wenn das
Hat mit der Körpermitte nichts zu tun.
몸의 중심선하고 상관없는
그럼 만약 저를 전치고 고철을 만들려고 하면 그것이
이거는 지금
In the ideal patient, you're right, but the functional hinge axis can be translated to some other position, so this relation is not necessary to exist.
저기 지금 이 두 분들이 이게 지금 예비진단 스타디 모델을 된다는 아니에요. 스타디 모델을 된다는데 그리고 여기서 다음에 다시 스크램프 만들고 나서 또 이 과정을 또 마운팅을 한 번 더 하는 거죠.
여기서 전치고 고철을 만들려고 하면
아니 근데 여기서 만드는 게 아니고
아니 만들 경우가 있을 거예요. 있었을 때
아니죠. 이건 지금 스타디보드를 진단하는 거기 때문에.
아니 결국 파이널 보솔도 이상해서 왁스업을 해서 만들잖아요.
아니, 다시 한번 하면 되죠.
Was ist? Next. Also,
아니
zum Auslocken oder so.
프로토 그러면
상황은
when
똑같아.
the hinge axis
상황은 동일하잖아.
상황 동일하잖아.
then the full mouse reaction
상황이 운동만 해봐.
상황이 운동이 바뀌는 거지.
das korrigieren, das nicht
Nein, kann man nicht korrigieren.
braucht man nicht.
Hinge-Axis muss respektiert werden. Kann man nicht korrigieren.
만약에 삐뚤어져 있는 거를 뭐 다시 잡는다고 제가 그렇게 여쭤봤는데 방향을 그거는 저기 코렉트 할 필요가 없다는 얘기예요.
Wenn Patient asymmetrisch ist.
Ästhetisch ist. The problem is that if you have a hinge axis which is tilted, the models will be shifted in the articulator, right? Okay, because hinge axis will always, in the articulator, hinge axis is here. So, in fact, the articulator is shifting like this, so the models are on the side. And the dental technician need to respect this for the aesthetic reasons. Okay, you understand? This is the problem. I understand your question, okay? Of course this is a problem, but in this respect you need to be aware, and the dental technician needs to see the photo of the patient, of course, that he can really relate it. But here are two different things. The one is the aesthetic question, the other is the functional question.
인젝스가 뒤틀렸다 하더라도 거기에 환자에 맞게끔 심리적으로 정융선을 맞추고 그 좌우교합 관계를 아까 시켄살
여기서 구현하려고 하는 거는 기능적인 거잖아요. 심리적인 맞출 수 없다는 얘기죠.
아니 이제
다른 요소로 봐야 되는 거.
아니 그거는 기공할 때 약간의 모양을 바꾸든지 그렇게 해서 컴프레스를 한다는 거예요.
Okay. Now after concentration, some moving. Light. So, anybody who has the computer with him, I put all the lectures on USB here. And for all of those that don't have the computer with them, I can make a shared folder online, and we can share by email. Maybe we can, I have maybe one partner of you, the company I will do with him, and he can share and send the link of share folder, everybody can download it, okay?
Willst du von der Patientin jetzt noch was zeigen? Oder? Weil das war gerade, dass wir die abschließen.
Ja, das machen wir. Können wir das jetzt machen oder vielleicht später, wenn du es montiert hast?
Ich montiere nicht.
Achso.
Ich greife jetzt nichts mehr.
Alles klar. Okay.
Da will mir nichts.
Dann würde ich ganz gerne ein paar Sachen noch machen und dann nachher. Okay, for further schedule, we will return for lecturing. What I want to do, from what I heard is we need to define starting position, which we call reference position. I will give a short lecture on reference position, and then we go back to the patient cases, and to finalize the day afterwards, we will discuss the data we just evaluated, and we try to correlate that with the clinical findings then, and my diagnosis. Okay, thank you. Yeah? Okay, so this is, just a second, to avoid, shit, sorry.
In the morning I go down and to eat the breakfast. I tell the waitress I wanted 2 pieces of toast. She brings me only one piece. I tell her I want 2 pieces. She say, go to the toilet. I say, you don't understand, I want no piss on my plate. She say, you better no piss on the plate, you son of a bitch. I don't even know the lady, and she called me a son of a bitch. Later, I go to eat at a bigger restaurant. The waitress brings me a spoon and a knife, but no fork. I tell her I wanted a fork. She tell me everyone you want a fork. I tell her you don't understand, I want a fork on the table. She say you better not fork on the table, you son of a bitch. So I go back to my room in a hotel, and there is no sheets on the bed. Call the manager and tell him I want a sheet. He tell me to go to the toilet. I say, you don't understand, I want a sheet on my bed. He say, you better not shit on my bed, you son of a bitch. I go to the checkout and the man at the desk say, peace on you. I say, peace on you too, you son of a bitch.
Okay, this is to avoid misunderstanding. Okay? Avoid misunderstanding. We have to talk about reference position to make clear. Condylography and reference position is the 2 core points of the concept. Okay? So, first of all, reference position needs to be reproducible. If you do it, as I said before, in a patient, it must be the same 2-3 times in a row. Reproducible. And physiological. But physiological in quotes, on purpose. I will explain later why in quotes. Reference position is starting point for assessing, diagnosing, and reconstructing the functions of masticatory organ. Going back in time. Monkey has very stable reference position. Monkey has, here is glenoid fossa. Okay. Monkey has bony support. No retrusive movement possible in monkey. Because of uprighting, head posture, and speech change human skull. And during evolution, we miss bony support. No more bony support. During evolution, this bone became temporomandibular ligament. And this is the question. Reference position is defined by ligaments. The retral border is defined by ligamentum temporomandibular. Temporomandibular ligament is the retral border, physiological border of TMJ. This is what it is. This is schematic drawing. This is mandible, this is condyle, and this is temporomandibular ligament. In our patient before, we palpated here, just below the condyle. This is protecting the joint against retral forces. It's a very, very, very strong structure. Okay? If there is strong force from up here, when chewing, temporomandibular ligament is protecting joint from going back. But if the joint and the ligaments are not in good shape, compromised, with so-called loose ligaments and functional problems, condyles can be displaced posterior and superiorly and transversally. If this ligament is loose or damaged, there can be more movement. Yeah. You can see here. This is the course of the ligament. Here. Ligamentum temporomandibular. Okay? In healthy cases, physiological, mandibular position is limited by temporomandibular ligament. For registering RP, this ligament gives us so-called zero position, our starting position, reference position. Nothing new. This guy said, sicher, the temporomandibular joint, clearly and simply, is a gliding joint. It can go a little bit back. In a healthy ligament, it will be protected. Okay, we don't need this. There is very many discussions about where is physiological position. Okay? Okay, this one. This is the current definition, American Dental Association, saying CR, centric relation, is the position of the mandible when the condyles are orthopedically stable. This happens when the condyles are in more anterior-superior position in the glenoid fossa, anterior to the bone, forward, while staying posterior to the articular eminence with the disc properly interposed. This position is independent of tooth contact. No dominance by teeth, centered by the muscles to the glenoid fossa into the cartilage, articular disc, and protected posteriorly by ligamentum temporomandibular. Okay? So, the definition of reference position would be unloaded or unstressed maxillomandibular relationship. No manipulation in this one. Okay? It is the retral border position of the mandible, not bone, ligament, in which the joint structures are unloaded. No force in any direction, and no tooth contact. Okay? This is a definition by Professor Slavicek in his book. This is the simple definition. There is 4 sub-points which are very important. Both joints are localized in their cranial, retral, and transversal border position. Upmost, midmost, anteriormost. With the structures of the joint neither being exposed to pressure or tension. Unloaded. The condyles are in close contact with the articular disc, which in turn is in contact relation with the articular eminence, fossa disc condyle complex. This position is purely joint relative, like in the ADA definition, and not determined by occlusion. This is why we have to put something in between. No tooth contact. And it exclusively depends and is influenced by the ligamentary suspension and defined by the muscles of the CMS, which is majorly lateral pterygoid muscle in superior part. Yeah? Okay? This zero position, neutral zero method, is from orthopedics, like for other joints in the body. Unloaded. We want unloaded joint structures. RP is unstrained retral border position from where all movements start. Every patient is moving from a zero position. RP, from my opinion, must be used for the analysis of all the cases. But this does not mean that in all our cases we use RP for treatment, because only if we have physiologic RP we can use for treatment. If we have deranged RP, like in our patient, strained ligaments, sensitive ligaments, something is wrong. We have to go to pre-treatment. Yeah? There must be, and this is our task, to find out physiologic RP or deranged RP. And this is a very simple scheme. If we have physiologic RP, we have unrisky patient, and we can go immediately to definite therapy. But if we have deranged RP, we must do initial treatment, pre-treatment, to make physiologic RP before definite treatment. Otherwise, very, very risky treatment. Orthodontics, periodontics, prosthodontics, implantology, very, very dangerous because invasive treatment, wrong starting position. You don't want to redo 28 crowns if you come up with a problem afterwards. Yeah? Ja, this is extended version. Okay, kannst du deinen Computer mal anschließen? Okay, now we will implement this thought of RP into the evaluation of the tracing we did in the patient before. Where is the, this is the sheet of the patient. Where is the? Ah, maybe over there. Maybe over there. Yeah, this is okay. In this patient, remember, okay, the right TMJ extremely sensitive, all ligaments sensitive. This is not physiological RP in this patient. This is deranged RP. But we don't know why exactly. We only have some idea in occlusion. We find medial-intrusive contacts, we find lateral-intrusive contacts, we find no good canine guidance, we find protrusive contact in molar area, and and we find very strong anterior contact in front teeth. But we don't know here, is this reason for problem here? But with condylography, we can find out. Okay? So first, we check the border movements. Please remember, x-axis, z-axis. Forward, backward, up and down. And here is y-axis, left and right. Okay? So, what we can see in the patient, normal length of movement, 10 millimeters, 11, 12 is fine. Same on the other side. But what we can see is here, not symmetric. Protrusive movement is strongly, highly symmetric, always. This is neurological reason, brain. The muscles are controlled bilaterally by the brain. So there is always checking. Healthy protrusive movement is always on zero line. If we see separation in and out, we know loose ligament, too much mobility left and right. And we can see a little separation here, up and down, we can see loose ligament in this one. So this is the confirmation something is wrong in the joint with the ligaments. In this first, let's go next one, please. Medial intrusion. Okay. Now, kannst du das Kreuz ans Ende machen, bitte? Yeah. So this is lateral intrusive path. Medial intrusion right means lateral intrusion to the left. Mandible is moving to the left. Yeah. Usually, in a healthy joint, we do have a Bennett angle. Bennett angle is transversal, should be this way. Bennett angle is around 10 degrees in a regular joint. It's straight. What does that mean? Assumption. She's avoiding something. Something is in the way of free movement. She's going straight, but at the same time going to the left. Something is disturbing her. And if we check medial intrusion right, can you see? she cannot go past this avoidance. So this can be interference. And then we look to other joint. Look at this one. This is the balancing condyle. The working condyle. What is the regular movement of the working condyle? Any idea? Usually, ideal is rotation along vertical axis around the 0 point. The 0 point of coordinate system is RP. Here, put the cross here, we can check minus 0.85 cranially, going up on lateral protrusion. And backwards. Yes. Going up and more backwards. Tooth contact on this side. Maybe avoiding this one. Yeah? And if we go back, which muscles would be avoiding this one? Which muscle will be sensitive? She's avoiding a tooth contact here. This movement is made by lateral pterygoid muscle. It's very sensitive. Here, the condyle is going back and up. The joint is positioned by CMS muscle. Deep masseter is positioning muscle of TMJ. Deep masseter, painful on the left side as well. So this is correlation now. Okay? Do other side, please. Utrusion. Okay. And the other one. The other one schöner. Okay. So this is other side, medial protrusion of the left joint. Rather regular path. Starting in 0, coming back to 0. Then an angle, not too bad. But other side, very strong deviation. Which is the joint that the patient has problems in chewing? Could it be? Minus 0.7. Strong deviation in the right joint. Okay. Now we check open-close movement, please. It's not this one. She didn't do. Okay. Again. Now, we said in protrusion, left and right asymmetry. If we check the starting here, it's very normal. And in the beginning, on 0. Open-close is a symmetric movement as well. But no asymmetry here in open-close. This means, open-close, no tooth contact possible. If we have deviation in protrusive movement, it must be tooth contact making deviation. So occlusion is the cause for deviation of the movement in protrusion. Okay? CPM. Und dann machen wir die Funktionen. Okay. Yeah. What we can see is very unstable joint. Not very good RP position, not very good ICP position. Always jumping around. Geh mal dahin, bitte. Okay. Welche ist das? Yeah. Okay. So, RP, no tooth contact. No tooth contact, unloaded joint structures. When patient closing to first tooth contact, both sides. Okay, premature contact. Now, ICP, please. Okay. This joint okay, ICP protecting right side, but left side, a little compression in the joint. This means some kind of shallow infraocclusion. When patient is going to ICP, joint is going up and back. Okay? And now we check functions of the patient, speaking first. Speaking as a protrusive symmetric function. So, and this is very impressive because it fits with the occlusogram as well. Protrusion, intrusion. We said it must be symmetric function. Back and forth, back and forth. Okay? What do you see? What is irregular? First, she's going strongly back. And second, she's deviating. So while speaking, she's avoiding this tooth contact in the posterior, left and right. And this strong front tooth contact, the mandible is kept back. If you observe closely, also when we speak with her, she speaks very quietly. She don't like to move so much because it's exhausting for her. She's avoiding teeth while speaking. Because a normal protrusive movement, she has a strong molar contact interference and she has two strong front teeth. And her speaking pattern is retrusively. Which structure is irritated here? This is bilaminar zone. Now we can check. Bilaminar zone is retral joint space. Open a little bit and put your finger behind the condyle. It hurts. She almost slapped me when I touched her. This is speaking function. Okay? Now, swallowing. Yeah, this one's good. Same. It's difficult to see. This is starting. When she's swallowing, she's going back as well. Because she's avoiding front teeth. And because molar support is not 100%, she's going cranially at the same time. Very shallow infraocclusion in the molar region. Okay. Mastication, please. And this is very impressive. Mastication movement. This is the beginning of the movement. Apple is soft. But already strong problem here. Going backward, deviating left and right, and later on, the skin of the apple, she needs to have real force. Here you can see this contact. This mediotrusive contact must be interference because when she goes close to her teeth, she's touching this tooth. And this is bringing down. This is distraction of the joint. This is pure functional distraction in the joint. And this is why lateral pole is sensitive in her case. The ligament is strained. And now the last function that we check is bruxism. Bruxism movement, we can check if she's bruxing, she's using the right molars and the left molars, clenching and grinding. Okay? More to the right side. And she's strong. Geh mal hier hin mit dem Kreuz, bitte. Aufs Ende. So, she's going back. She's going to the right side and she's going up. Especially backward. Which ligament would be strained? ligamentum temporomandibularum, the retral protection. And we palpated that, and it's painful, especially on the right side in her case. So is occlusion important in this patient? No. This is now proof that our hypothesis that she has occlusion problems in dynamics in all functions causing her TMJ problem. Occlusion is responsible for high muscle force and wrongly directing the forces into the joint and straining the joint capsule since many years in this patient. And I'm very sure this is why she has problems in the neck, and I'm very sure that this has a strong influence to her headache. She has headache once a week. What is your proposal now? What do we have to do with this patient? Two things in the first place. This is deranged reference position, not healthy joint position, because occlusion function is making unphysiological movements. So we have to give patient some relief first. We have to make sure ligaments can heal. First step must be pre-treatment. We cannot go directly to occlusion. No irreversible treatment. Too difficult, because probably after pre-treatment she will recover. Ligaments will strengthen. All this will look different. So we cannot go to irreversible treatment. We must do occlusion treatment, but reversible by splint. Yeah? She must have RP splint. And make sure that in RP splint, nice movement, but no posterior interference in this case. So all these vectors in the joint, can be eliminated. And then, after a couple of weeks, we can go back and we can repeat this. We can repeat occlusal index again, and then we can see if we are successful. If not successful, if maybe shoulder pain stays, we have to send to specialists. We need help of orthopedic specialists. Yeah? Okay. Any questions so far? I would say about 6 weeks. Yeah. In this case, 6 weeks. But you should check splint after 1 week already. If diagnosis is correct, within 7 to 8 days, symptoms must go down. Very quick. System is very quickly responding. Muscles are immediately reacting. Within 20 minutes, patient will have new muscle movement if you avoid old occlusion. So it can be very quick. Very quick. But patient, I think, needs to wear splint 24 hours. Because speaking, clenching, mastication, and swallowing is compromised. So we have to control patient around the clock. Okay?
What kind of splint do you use?
RP splint. RP splint. RP splint means we do RP mounting in articulator. Usually incisal pin will be 5 millimeters. A very thin splint. And then you have good posterior support. 7, 6, 5, 4, 3. Strong contact. Not so strong contact for front teeth. So patient can go forward.
여기서 말하는 RP 스플린트가 RP 그 포지션, CR 포지션이 그러니까 이 도승 메소드로 하는 CR인지 아니면 이걸 지금 기준으로 해서 만들어주는 CR인지.
RP 포지션, CR하고 상관없나?
지금
조금은 잠깐 차이가
시간 얘기
지금 RP 포지션에서 RP 스플릿
Jet lag. RP splint and CR splint, very close together. It's just the name. Okay? RP is almost the same as CR splint. Yes. Again, RP position, splint in RP position is RP splint. Reference position splint. Yeah. This position. Stabilized joint in this position. Okay?